My name is Fabi, and I am a medical foster parent in Alaska, and I'm in the process of adopting my son, Chad. We got John when he was 6 weeks old and learned that John had a condition called tetralogy of Fallot with pulmonary atresia and MAPGAs. His heart does not work the way that mine and yours does, and at 6 months old, he required his first open heart surgery. So in addition to the medical issues, we also have the foster care system that we work with. And not only does he have medical trauma, he has previous trauma. Like, we didn't get him until he was 6 weeks old. And up until that 6 week point, he experienced some pretty extreme trauma. You wouldn't think that, 6 weeks was a big deal, but 6 weeks is a huge deal considering they weren't just with their biological parent for 6 weeks. He was with her for 9 months in her womb before he was born. And then he got to experience those 6 weeks, and newborn attachment is essential to having a good outcome. And then at 6 weeks old, he was ripped away from everything he knew and put into a home that he was completely unfamiliar with. So, there's medical trauma that he experiences, and then there's also the trauma that comes from foster care. And, kids in foster care experience a lot of things, especially substance abuse, problems with their parents, or neglect. And even before they're born, they can experience these things. So it helps to remember that trauma starts before birth. Trauma-informed care is understanding that we all come from a different place. Different life experiences create trauma. And then when we shift things, we create more trauma. He has multiple traumatic experiences, all grouped into one. It is a medical experience, it's social experiences, and understanding how all of that comes together is how we understand trauma care.
Good afternoon, good morning. It's wonderful to be with you. Speaking to this subject speaks to the deepest places of my heart, and I'm always grateful to be in these spaces with like-minded folks, so thanks. Early on in my career, I was a PRN social worker at Primary Children's, so I know there are some of you here. Shout out to my fellow colleagues. And it was among my roles to be there with the family when a child died, which was particularly challenging as a PRN worker because I had no relationship with the families, almost always no relationship, and coming into the most difficult moment really in their life. And as difficult as that work was, I learned to truly love it because I learned very quickly that there was literally nothing that I could do to change the circumstances, right, of what was happening, but that it was simply about my presence and how I was showing up with families and what it meant to be with them and hold space with them. And I will always remember several of those moments, but one in particular was a young mom who had lost her 9-month-old daughter and was having a hard time putting her child down and walking out of the room. And I've told this story so many times, and it's still. So I offered to hold the child so that she could hand off to a set of warm arms instead of leaving the child alone on the bed and walking away, right? And I think about that moment a lot. What it means to literally and figuratively hold space, right, for these families, how we show up with our own humanity, how we show up and see their humanity and their needs. That was the most important moment in my interaction with her that day, right? Was doing that. And I won't proclaim to do that perfectly, that I've done that perfectly in every moment in my career. But I think about that a lot, and really that it's the way, it's the path as much as the destination that we're talking about when we're talking about trauma-informed systems. I am assuming that you all have a sense of trauma-informed theory. We're not going to talk about that. But I do love just the reflection on the overwhelming of our coping skills, because that shows up differently at different points in our life, right? So when we talk about trauma-informed systems, we're talking about all of the life experience that we bring with us into the room. And we're also talking about the moment of interaction with you as the practitioner or as the whomever in their life, and what else is going on for them in that moment, right? What else is going on for us individually in that moment? Am I secure in my relationships? Do I have a support system? Do I have economic foundation? You know, all of the things, right? And it's a good and important reminder about how we individually show up, as well as an acknowledgement and an understanding of how our clients are coming into that conversation with us and what it is that they need from us. When my second daughter was born, she was born a little bit early and immediately developed an infection in her lungs and was in the NICU. I had come through a difficult birth, traumatic birth, and was recovering from a C-section, and my brain was in a fog. And I, even in that moment, was coming with a lot of privilege, right? I had a very supportive partner, had family outside of the hospital caring for my other kids. I had an education that could, encourage my understanding of the concepts that they were explaining to me. But there were several moments in that 3 weeks that we were in the NICU that I simply couldn't take in. I couldn't hear, right? The physician was telling me that my daughter would go home in 7 days. So I started counting 7 days from the day that she was born. And we were about day 5.5 when I realized that he said or meant, she'll go home in 7 days from these benchmarks, from this kind of moment in her care. And another moment where I would sleeping at home, I would go and spend my days with her. I would call the hospital at 6 a.m. because I wanted to hear from the night nurse how she had done with her eating overnight. And it was important for me to talk to the person that had done the thing, that had cared for her, because I needed to know, was she feeding like this? Was she feeding sideline? Like, how was she, taking in the food, et cetera? And I had worked out with the nurses that moment was an important kind of translation for me to understand what had happened overnight. And then I could show up in the morning. And then you get a different nurse the next day that doesn't get the same information, and I got met with a you can't talk to the nurses right now. This is transition time. This is the transition hour that the nurses kind of transition their schedules. Now, I knew my daughter was getting wonderful care, and there were so many moments where they did show up in compassion for me. But those are the moments where how conscious we are of the brain function, of the emotional function, of the mental function of the people sitting in front of us, and how we need to show up with and for them, right? I mention, when I talk about trauma-informed systems, I've loved this conversation today because I think so much of it is framing around trauma-informed care. So this is not that moment. It's been really the conversation today. And we talked about theory, or we understand theory, but I think a lot of us then don't know what that looks like in practice. How do we translate trauma-informed theory into a trauma-informed system? And so I talk about it in these 4 ways. The first is around centering and celebrating our humanity, which is just very simply, the understanding that we're working with human, that they're bringing into the room all of their stuff. And the truth is we are too. And so how aware are we of our own acknowledgement? How conscious we are of designing our systems and our interventions around that. We all have protocol and checklists and intakes and all of the things that we have to get through, and there are reasons for that. But have we slowed down enough to even in those moments say, I've got a lot of questions that I need to go over with you. These are the reasons that I'm going to ask them. I'm wondering if you'd like to take a few minutes now. Would it benefit you to do this now or in an hour? Giving a little bit of, just a little bit, right? A little bit more room, a little bit of autonomy, a little bit more choice in the process that allows for that kind of human to show up. It is the practice of emotional intelligence, and I say that for ourselves as well as for our clients. What can we do to support them coming into their body, kind of working through that brain fog in the moment, making sure their feet are in their shoes and we're on the same page about conversation. And the way that we can do that for them is that we have to do it for ourselves. So how prepared are we to walk into difficult moments, important conversations with clients, or are we bouncing from client in crisis, from crisis to crisis to crisis? Even taking a few minutes before walking into a patient's room to center ourselves, taking some deep breath, engaging our senses, all of the things that bring us into our own shoes so that I'm fully here for you, right? How are we reinforcing safety? Again, starts with our own emotional intelligence. And for the clients that we're serving, is all about trust. And trust is built in very small ways. We don't get it just by being their assigned person at the hospital. We have to show up. We have to be consistent. Consistency breeds safety. Safe relationships are the antidote to trauma, right? And so how do we show up and be consistent, follow through with our promises? This morning, we talked about the Ronald McDonald Family Room. Can I walk you down there now? Can I show you how great that, that resource is for you, that we follow up with the things that we said we were going to do? And the last is around that acknowledgement of loss. We work literally in a field where we are losing people, we are losing bodies, we are losing humans, but that is also not the only thing that our families are losing. They're coming to the hospital, they're coming to our care, they're coming to our behavioral health care, and they've just lost a sense of normal, a sense of next week's plans. They're no longer with their dog and their favorite stuffy and their friends from down the street. There's an incredible amount of loss that's present. And it's present whether or not we say it out loud. So I think part of that humanity and that bridging is that acknowledgement is, oh, you guys are a long way from home. What are you missing the most? Just in the smallest of ways, just acknowledging, like, oh, you have a dog. Tell me about your dog. What is he? Where does he sleep? Does he sleep with you? I bet he's really missing you. Just acknowledging those moments and also acknowledging that loss for ourselves. And the last panel kind of talked about this, like how do we show up in our own humanity and how do we take care of ourselves so that we can show up as our best, right? The last thing I'll just share is that, this is really the call in around that wholehearted leadership. And this is tough work. It's not easy to show up and do this again and again and again. And so how intentional we are, this has to be a decision that we make early and often about how we're tending to ourselves, so that we're able to show up for other people, and how we, fight like hell within the systems that we have so that we're designing them for the humans that we're interacting with. So I'm so glad to be here and be a part of the conversation. Thanks.
Thank you. Stormy, are you?
Yeah, hello everyone. My name is Stormy Nilsson. I am a licensed clinical social worker, and I'm also a transracial adoptee. That was not necessarily a title that I always give myself, at least growing up. And then when I moved into the clinical space and made that my clientele, I do feel like that is an important part of, my story and my mental health work. So I do share that. But a little bit about me. I was raised down in Utah County, grew up in a house with 6 siblings, 2 parents. All of us kids were adopted, and all of us kids were adopted transracially. So for those that don't know what that means, it's kids adopted from one race into another. So my parents are white, and the rest of us are Black. And that has its own journey, if you will, to it. So somewhere along my journey, I thought I was going to be in healthcare and like the nursing field, and math and science was not for me. And so somebody introduced me to social work, and that really became my passion. So I've worked in behavioral health settings, residential treatments. I worked with youth in foster care. I've worked with youth in JJS custody and at their secure care, and have kind of, in all that, ended up moving to private practice and thought that, it was my time in residentials where I was recognizing we have all these kids coming back into care. We have all these adoptions or all these kids who are adopted who are coming back into care. And if you look at some of the statistics, families of adoptees are, I think it was like 60% more likely to utilize mental health services than non-adoptee families. And then also when it comes to behavioral health services, I think it was like 4 to 7 times more likely to utilize residential services than, again, non-adoptee families. So when I started recognizing these outcomes being in residential settings and providing like adoption-centered groups in those residential settings, I said, how can I help? I had a colleague and we sat down, talked about just our journeys as transracial adoptees, and some of the gaps and barriers that were missing for us in our own upbringings. And in that, there was 3 of us at the time, there's 2 of us now. But in that, we were like, let's create a place, let's create something where we can provide the education, workshops, resources, not only to parents, but for adoptees as well, and kind of create that safe space. Something that we recognize a lot in the adoption setting is a lot of, I guess, invalidation for the adoptee and their experiences. A lot of frustration from parents where, they're calling and saying like, I didn't recognize that these things were going to be as important as they are, or, we've been to therapy before, but my therapist has not touched on this adoption portion, has not touched on the race portion, and that's what my child is struggling with the most, And so then they come to us and it works. But there's just a lot of areas within adoption that is not talked about in the ways that it should be, or validated in the way that it should be, to provide some of that preventative care so that we don't have these children ending up in higher levels of care. So on this slide, I said that the data was kind of inconclusive. There is data out there, but there is limited data out there specifically for the transracial adoption population. And Utah, being the large family state that it is and very much pro-adoption state that it is, we've got a lot of transracial adoptee families in Utah, and that population is continuing to grow. But I've had so many conversations where we're like, how are we keeping track of all these transracial families, especially ones that are moving in from out of state, when you are filling out a census for your neighborhood or for your house, are you marking that you have multiple ethnicities or races in your home and in your family? Is that being counted for or not, So those are questions that we definitely have to consider when we are, talking about the transracial adoption experience. So within the adoption world, there's talk about adoption as trauma or adoption trauma. There's some conversations around, is the physical act of adoption itself traumatic or not? Which there's many scholars who would say yes, but then there's also the journey of life after adoption. In the video, she pointed to just the fact that trauma starts before birth. There's a book that I really like to read all the time, reread it just probably last week, but it's called 20 Things Adopted Children Wish Their Adopted Parents Knew. And it's fantastic, yes. That was actually a book that very much became my catalyst of like, okay, I'm feeling more competent to be able to work with this population. But that book speaks more toward the behavioral outcomes and the adoption trauma, not necessarily the racial piece, but when you are working with children who are adopted and teens who are adopted, what are some of the behaviors that you see that might be more so related to the adoption grief than what we're, recognizing? And how do we work with kids and acknowledge those pieces and parts of their journey and their experience? And so for me, when I think about adding on the layer of race to that, there's just a lot more to consider. So focusing on the grief part, right? We've got separation from family. Again, she talked about trauma being before birth, when you've got these birth moms carrying this baby. A lot of the times babies that are adopted or children are adopted, they're not being adopted out of like these great grand circumstances. There's usually some trauma and some anxiety. But if your universe is your mother's womb for 9 months, and then that is what you're kind of taken away from, where you don't get that skin to skin, in those first few hours, and that doesn't continue, and then you're just kind of taken away from all that, that does become a traumatic disruption to that baby's development in some ways. And again, if you are this parent who is in a high stress environment or is dealing with substance abuse or whatever it is, or is in an abusive relationship, or if, I've met a lot of adoptees who are products of rape, and when you're dealing with all those different things and the stress is what you are taking in as a baby inside your mother's belly, that predisposition, that is something that's going to continue over. So there's just a lot of work to be considered. A lot of parents, and I guess this is my own thoughts and feelings toward the way that we view adoption. There's a lot of talk of, I just need to bring these children in and shower them with love and things will be fine. Or you think that because you're adopting a baby specifically, that you kind of have this blank slate of a human, but that is absolutely false. They come with their own things, and that does need to be considered when you're trying to integrate this child into your home. So just different things to look out for. A lot of our youth that are adopted, specifically transracial adopted, right, there is those school challenges that they're dealing with. And again, some of that does become neurological, developmental in some ways. There's increased hospitalization, like I did say, physical health issues. We recognize that somatic symptoms are a thing, and also just, again, that interconnection between mental health and physical health. And so if I've got spiraling mental health issues, which again, a lot of adoptees do, then sometimes you do see more of those mental health issues. One thing that I was going to add, kind of with my whole family system, I have a little sister and love her to death, but she has definitely struggled more so than the rest of my siblings when it comes to developmental stuff and just adoption trauma. She is grown now, but also my parents have utilized the Ronald McDonald House at different times during her upbringing, just because she struggles with sickle cell anemia. So she, a lot of the time, is up here, primary children's, but adding on, I guess, her medical trauma, because again, we have increased medical issues. Granted, she came with genetic medical issues, as well as just the mental health struggles that she's had to deal with as she's navigated not necessarily just her racial identity, but biological family and adoption trauma related stuff. So another, I guess, important piece, so I don't skip over it, is we are here talking about like family-centered care. And when you are dealing with children who have different levels and layers of trauma, specifically adoption trauma, that does affect the whole household in so many ways, whether it's you're bringing a child in and you already have other kids in the home, that disrupts certain things there that need to be considered, or you've got, it's like new baby and just the stress there, or your kid is getting older and they're starting to recognize different things. They're dealing with different racism and microaggressions that they're not prepared for because, again, race is different than culture. They're dealing with different stressors sitting in class because everybody's talking about genetics and biology and they don't really know those parts of themselves, or they're sitting in a hospital room and they're being asked their medical history and they have nothing to fall back on, like all those things are stressors and traumas and can cause behaviors in children that parents are now having to deal with at home. And so when we are working with these individuals, we definitely have to consider the whole family, which means a lot of education for parents sometimes, and teaching them a lot more empathy and how to respond to the child's own process of grief and adoption that they are dealing with. Let's see. Yeah, I don't have too much else, but that's kind of our specialty at Focal Point. So we serve largely transracial adoptee population. We also serve a lot of BIPOC population. Right now, all of our therapists are people of color, which has been really helpful. I don't remember who it was, but they talked about having therapists who mirror you, who look like you, type of a thing. That has been definitely a factor in the clients that we have served. Like I said, we are all transracial adoptees at Focal Point and have very much found this as a passion of like, how do we give back to this community? I had this one client, love her to death. When she was passed to me after discharging a program, talking to her other therapist on the phone, it was met with, this child's going to fail. She's going to like relapse. She's going to whatever, like parents are going to slide back, like good luck, But day one, she sat down in my office. She said, "You're Black, you look like me, you're also adopted. Cool, what do you need me to do?" And we got it done. And she's doing so good and it's great. So, racial mirrors are important. Representation matters, like was said by Greg. And just, I guess, therapist competency when it comes to working with certain populations. So, yeah.
Thank you very much, Sonia. Now I'd like to turn the time over to Dr. Brooks Keeshin. Brooks and I have known each other for many years, and I like to think that I inspired him to grow his beard. Yeah. So
I am so disappointed in how short your beard is. I was thinking, I need to keep growing this out to compete with Orly. And
yeah, it used to be a lot bigger.
A lot bigger. So good to be with you all today. My name is Brooks Keeshin. I'm going to be talking a little bit about the Center for Safe and Healthy Families. And I just kind of want to reflect for just a second. I love the idea that we're having this conversation around trauma-informed care and how we're beginning this with talking about professional roles and sharing personal experiences and how they really intertwine, right? It's kind of a false pretense to say, we got our professional stuff and our personal stuff, but they really do come together. And that kind of is also how I started to think about trauma-informed care when I had been raised in an environment that was really trying to adapt more family-centered care in the first place. And then I started reading on trauma-informed care. I'm like, I thought I just read about this because this is what we talked about in family-centered care, but using some different words and some different concepts. And so, I think from a main takeaway point, when you are engaging and doing work with individuals who have experienced a wide range of trauma, trauma-informed concepts and a trauma-informed approach are really critical to doing that work. A system that supports you in doing that work is absolutely critical. And then what I want to talk about a little bit today in terms of the small piece that we play in all this is that having specific tailored resources for individuals who have experienced childhood trauma, traumatic stress, child abuse, PTSD, having access to some of those resources in a very kind of unified space also really is critical for both the individual professional response as well as the system professional response. When we know that we can do all of these things in a family-centered, trauma-informed way and show up to the families, to be present for the families, to share our lived experience and use that as a way to connect with the children and families we're serving, and to also know that in the most significant or extreme of circumstances that there are folks that really just do trauma as either a resource, a backup from a clinical standpoint, from a training standpoint, just from a collaborative consultation standpoint, we're able to do so much more. And so, what I would want to kind of just share are a couple of points in terms of how do we think about the Center for Safe and Healthy Families as part of that piece for us. I want to start with kind of just acknowledging that we are a medical clinic, so an integrated care clinic. So we have a behavioral health arm as well as a medical arm that focuses on identifying and responding to child abuse in the moment. But then we have a behavioral health team that works with families that have struggled with child abuse and other significant traumas. And so from that context, we are foremost grounded in the same type of science that you would expect from any other professional that you'd be getting at the hospital. So that really drives our evaluation process, it drives our treatment processes, it drives how we measure outcomes. And I think it's important to highlight that piece early on. Like there's so much in the area of trauma, and there's so many different ways that trauma impacts any individual child. So you're dealing with a lot of variation there. The more that we can then, for the families that we serve, recognize that we are doing things that not only are trauma-informed, but are evidence-based. Like we know that when we do these and do these well, more often than not, kids get better. That also is something we really need to owe to the families, that we need to honor the fact that they're sharing their experience with us, and we're going to do the things that we know and have the best evidence for, while of course adapting that to the specific needs of the families that we're serving. A couple of things that I'm just going to run through real quickly, because when you tell a child psychiatrist to talk for a little bit, that can go long. So I'm going to use my notes to keep on point, and then we'll open up for our broader discussion. Dave Corwin was the center director at the Center for Safe and Healthy Families for a number of years. Some of you might still remember him. He's still around. He's always really willing to have a phone call. He was director of the Mayerson Center for Safe and Healthy Children in Cincinnati before he came here. And he speaks with great pride about the fact that not only did they were not allowed to steal the name from Cincinnati when they were coming up with the team name for here for Primary Children's, but that the choice was to call it the Center for Safe and Healthy Families. So like very much at the very forefront, like family is part of the name. And as you think about the things that we do in our process, whether it's from the intake, which is a personalized intake with a specialist who understands our treatments, understands how to work with parents who've experienced either their own trauma or the secondary trauma that their child has gone through, and can help provide guidance, not just for what's going to be helpful, something that we can do for the family or something we can help connect them with that's not within our scope of services, as well as meeting the needs of that parent. That's all part of our initial over the phone. You think you're just calling to schedule an appointment. No, it's really a 20 to 30 minute conversation with a specialist who knows trauma, knows our treatments, and is specialized in working with families. After you get through that process, we have an evidence-based trauma assessment protocol. And it's not just geared towards identifying, bad PTSD or okay PTSD. it's really geared towards identifying parts of the relationship and where there's strengths and successes, where are there parts within the family relationship that are struggling. Like it's a strength-based psychological brief assessment that we do. We're looking for those opportunities to really plan and tailor our intervention to meet the specific needs of the family. And then the treatments that we offer 4 or 5 evidence-based treatments, but 3 that I want to highlight: trauma-focused cognitive behavioral therapy, child and family traumatic stress intervention, parent-child interaction therapy. 2 of the 3 actually have parent or family in the name of them. And I'll tell you that if you know of a provider who delivers trauma-focused cognitive behavioral therapy, and they say, yeah, I do that because I like working with kids and I don't like talking to adults that much, they're not doing trauma-focused cognitive behavioral therapy. If a parent describes that, yeah, I take, my kid's getting TF-CBT, trauma-focused therapy, I drop them off, 45 minutes later after I run some errands, I pick them up. They're not getting trauma-focused cognitive behavioral therapy. So our therapies are evidence-based. They're manualized to kind of help us through the steps that we need to do to walk these families through towards a path of healing. And they're designed to be adaptable to the specific needs of an individual family, the specific strengths that a family has, but that we're going through a process that really leads to the last point of what we do at the Center for Safe and Healthy Families, which is we want to fill that balance of being available, being present, walking with the family during their journey to recovery, but also recognizing that we are a system that has been artificially inserted into their lives at a time of crisis or identified need. And so part of treatment is removing ourselves from that process. So I think it's, in some ways, we think of, we are a specialized clinic and, we do these things. And once we're done with that, it's over. But I actually think from a family-centered approach, that's really honoring what the strength and the capacity of the family, the identified family, whether it's a traditional kind of biological or adoptee type of situation, whether it's a broader family that has multiple kind of adult and maybe younger adult people that are in key in that child or adolescent's lives. But it's really setting from the very beginning that we are here for this part of your journey, but your journey continues. And part of our treatment is actually making sure that you have the skills and the supports and the resources to successfully leave our clinic. We're not here to be with you throughout all the time. It's that's the point of your family. That's the point of your community that you're with. But saying that really upfront as part of this process, I think is really key. The last thing I'm going to say before I give up my time, because I wanted to highlight just something that was kind of said earlier in the prior panel, but that kind of links to this idea of the behavioral health system and the trauma-informed system. I think it's important to recognize that a lot of data we have right now when it comes to the mental health crisis that children and adolescents are facing in this country is based on the type of data we typically collect. And one of the types of data we don't typically collect is data on trauma, because trauma is messy. There's lots of issues around collecting data around trauma. But I want to leave you with just a couple of numbers to keep in your head. When we look at primary care clinics across the Intermountain region, so the 20 pediatric clinics that are seeing just kids off the street that are just getting regular pediatric care, as you would guess, we are seeing high levels of kids just coming in for well child care, reporting significant anxiety and depression, right? I mean, is that news to anybody here? Okay. So what I want you to, 801-662-3600, that's the number for Safe and Healthy Families. So that's one number that everybody should know. But if you remember only one other thing from this today, when you look at our teens, so 11 and older, who are coming in for primary care, they're not coming in for mental health complaints, just primary care, well child care. When they have a high depression score, so on the depression screener, say it's 20, 21 or higher, one of the ones that really makes us concerned. When you start measuring for trauma and traumatic stress, it's not that 50% of those kids with high depression scores have experienced a trauma. It's actually that 50% of those kids who have high depression scores actually likely meet criteria for PTSD. So when we talk about trauma and trauma-informed care, it is not a one-off. It is not a little group here. What we're talking about is that it's an underlying driver of a lot of the behavioral health and a lot of the mental health crises that we see. But if we don't screen for it, if we don't measure it, if we don't look for it, we often miss it. And that's something that we are trying to design our systems around. And thank you very much. And I'm going to go for your questions.
Thank you. Thank you. And I love that I kind of heard of a theme through all three of grief as well. And as a grief counselor and specialist, like I appreciate that. Thoughts, questions for this esteemed panelist? Yes, Emmy has a question.
Just what you said, Brooks. Yeah, me and my loud mouth. I don't know about the mic, but when you say we don't screen and trying to be holistic about things, are we doing any better even, or would you see value in like practices that are actually doing ACEs assessments, right? Is that even a place to start in identifying trauma experiences within families in a PCP setting?
So I'll just briefly say that I think the jury is still out on the value of ACEs screening in primary care. At a population level, ACEs is really informative. At an individual level, ACEs is not as informative. So the difference between ACEs screening and trauma screening is ACEs is looking at kind of the overall load of adversity that an individual has faced. Trauma screening is looking for specific types of lived experience that primary care might be able to respond to. And trauma screening that includes traumatic stress screening also looks at whether or not some of that individual's reactions to their lived experience, their trauma, are the types of reactions for which trauma-focused treatments are helpful. So trauma screening is more specific to the experience and what can be done right now. ACEs screening at a population level is very helpful, but I think we're still trying to figure out what an ACEs burden truly means in terms of healthcare delivery.
Thank you.
Rebecca, and then over here.
I'm going to apologize at the beginning because this is probably more appropriate for like a long-term lecture. But I've got a question for Stormy. I have some children that I work with that are interracial adoptions. And we recognize, and I'm very familiar with also the trauma that's gone behind that. Parents have not asked me to address it. These children are young enough, I don't know that they have the verbal acuity to ask about it. I'm curious as to what you would recommend from your personal experience and working experience on the best way to even sort of, this is going to be a long-term relationship with these children. Best way to handle it, I cannot change my race. I don't want to change my race. And theirs is different than their parents, which matches mine.
So it takes a community. We are a village and we have to be a village in those things. I did a support group last night for our adult adoptees. And one of the things that was mentioned was I didn't need meds. I didn't need this. I didn't need that. I just needed community, And so community is important. I try to stay connected to the communities that match, I guess, the race and ethnicity of my clientele, because there's only so much work you can do in the office. But we know with all of our clients, right, the relationship is about trust, and you're dealing with attachment wounds. Therefore, knowing how to build that trust and create a healthy attachment with your clients is going to be helpful. I think in time, when they feel ready to talk about certain things, that they will. But I also want everybody to acknowledge that children who are adopted are always thinking about their adoption in some way. We did our camp with Domino Foundation. Domino Foundation is two parents who have adopted transracially and started a foundation nonprofit to give education to parents about some of this stuff a little bit more. And while we were at camp, we were having discussion, talking about experiences. And one woman shared an experience with her son. They were driving to Disneyland, and he just had a breakdown in the back of the car. And, I think at the time he was 8 maybe. And she was like, yeah, what's wrong? What's happening? And he's like, I just really miss her. I just really miss my birth mom, So it's just things like that happen. And, I had a client, super sweet, super innocent. He's out on family vacations and they're having fun, but he's sad and just wishes that his birth mom could experience those things with him too, that's what they're thinking about. But there are, especially if you read that book, 20 Things, she does talk about different activities in there. I also have some different activities as well that I could email over to you as well. So, yeah.
Thank you. You had a question as well, correct?
Yeah, this is for Brooks. I work on the stabilization mobile response team, and we get a lot of crisis calls where there is a lot of trauma in the kids, and we refer them to safe and healthy families. I guess my question is, like, what would be good dialogue for parents to say, like, how long, like, the wait list is, or what we can do to help the kid until they get into like safe and healthy families? Does that make sense?
Yeah, so two things. One, in terms of the wait list, we intentionally keep our wait list pretty short. So, and we work hard to also triage so that there's a really high needs family that we are able to get folks in. So we try to keep it short. That's our goal. In terms of the dialogue and partnering around between the time of kind of a mobile response, maybe crisis stabilization assessment and getting in, I think that there's a number of the initial psychoeducation, relaxation, and coping skills that we use. And we actually have a model within the Intermountain system called the care process model for pediatric traumatic stress that actually encapsulates a lot of the first couple of types of activities that we do in trauma-focused treatment. And so that's something that I think, looking at that and thinking about how, if we're going to have several more contacts, those are types of activities or guidance that is going to be very consistent with what we would be starting once they get in through the doors. And we've actually been able to effectively partner with pediatric clinics and even children's justice centers across the state to start activating some of those responses to target some of the more pressing trauma-specific symptoms that the child and the family are experiencing. And so then we can just kind of pick up from that as we move forward with the family.
Thank you.
I'm going to try, this is a question for whoever, and I will try to articulate it the best that I can. We talk a lot about family-centered care in the context of how are we supporting the pediatric population, but then also there's these parents there, right? And those parents are also seeking care elsewhere for all of these same exact things. And so how do we better prepare our parents that are caring for these medically complex children with mental health issues that may not have the skill set themselves, but we're expecting them to have that skill set. And in that setting, they don't know what they don't know. So I guess my question would be is, as a community, as a system, what are we doing to better prepare parents and their parenting journey? Because that seems to be a crisis in our society right now as well.
I have a few thoughts, and I'm sure my colleagues do too. I think early and often, I said that earlier, but early and often we are acknowledging at every point in the path what may be going on for them. This is a lot. This is hard. This may feel overwhelming for you. I'm here. We delivered some tough news yesterday. Would it be helpful for you if we went over that again? Or do you have any questions? Like, just being really mindful about how things are landing. Then the next step is have some more information when you're ready. Have some more resources when you're ready. And that comes back to our consistency and our follow-up and our ability to help them feel safe so that when they're ready for the next step in the journey, that they know where to come back to. I think Stormy's point earlier about community, is a really important one about there are other families managing exactly what you're managing, and I'd love to introduce you, but really kind of walking them through, nudging them, but also encouraging some autonomy in that moment. You're feeling like you've been hit by a truck, and like you said, you don't know what you don't know, and so having somebody to kind of hold hands with along the journey, I think is really important. So that's what's coming up for me.
Just to add to that, I feel like in something that we should get used to kind of in standard practice is if we're working with youth, we should always be working with the parents. I think it's very common for, people drop their kids off, they take it as their free hour and then they leave, But if it's about the family and it's about how the child is behaving at home, then there is 100% no reason why the parents should not be involved in a decent amount of those therapy interactions as well. And so I think if we can adopt that kind of as best practice, that would be helpful.
Yeah. Go ahead.
I was going to say one last thing. I think it's really important for pediatric providers to also feel like they can get outside of their comfort zone in terms of assessing, at least briefly, the needs of parents. So we are able to do like, postpartum depression screening. It's part of the AP guidance, like we do that routinely. It's required a lot of handholding and support to get pediatricians and pediatric providers to feel like, oh, I can do this. And so, trauma is the same way that, the ability to also kind of have enough understanding to give meaningful, accurate guidance back to that parent, that is within our wheelhouse. And it's part of trauma-informed care that is family-centered and focused on the child, like is actually helping, providing some of that kind of more, not taking the place of their own mental health provider, but actually giving some, like on top of all this, there's validation, there's the resources, and there's like, yeah, you're right, like, if you don't get your own, like we can assess and say, hey, yeah, this definitely warrants getting help because of X, Y, and Z. Like that's not getting out of our lane, I think, because that's just providing additional information.
And I think looking at a parent's willingness to accept some of that help too, right? Like they're overwhelmed, they're another team, another thing. What else is on my list, right? Like so much already. Yeah.
So something that's been coming through my mind, you just kind of alluded to it, is when I was working with kids in drug and alcohol recovery at Odyssey House and trying to get the parents on board. It was, like you said, the kids are in residential treatment. I facilitated family therapy. We're talking about family-centered care. And you knew the home life that these kids were coming out. You're trying to work with the families without demoralizing them or telling them you're not managing your home well. But what was hard for me is these kids would do 12 months in this program, very little support from families, but they could not wait to get home and go back into those families. And so for me, the challenge was how do I help these parents even parent a little differently than they had been, but so many of them were not receptive to that. And that was really challenging. And as I keep looking at this family-centered care, I think that's a real big obstacle for a lot of people in this room who are working with families, especially families at risk, is how we get those parents. And again, you kind of said it, they've got so many different things going on, whether it's unemployment, whether it's domestic abuse, substance abuse, and how do we get those parents to engage in the treatment of their children?
Tracy,
I have lots of thoughts about that, but one specific, so many families, I think, come with the trauma of their own parent, and so I think we spend a lot of time lying about it, not being honest with ourselves, but lying to our system partners, trying to mask that all that behavior. And so just that relationship of trust and that idea of giving people hope that things can get better and giving them an opportunity to see other people who are like them who have got better or whose children are doing better, and that you have a stake as a parent, you have a stake in helping your family to do better. What do you want? What does that look like? And how do you get past those defense mechanisms that those parents are putting up, right?
Right. Very good. True.
Yeah, right. All the things that we learn as kids to survive in our families that no longer serve us as we become adults, and how do we start working on that stuff too? Yeah.
Can I add one thought to that? This is part of that showing up in our humanity, and I think we tend to. We're clinicians, right? So we speak a certain language. You talked about that earlier. And so that feels really overwhelming to our families, obviously. Being able to say to them, oh man, I'm a mom. This is hard. I have a master's degree. I've been through a lot of stuff and I don't know what to do with my 4-year-old when she's bouncing off the wall. To show up, I think sometimes in our own reality, especially for those families that feel really disenfranchised by the systems that we are promoting or are within. And being able to model that path a little bit, like here are some things that have helped me. Is there anything that you're worrying about, that can I connect you with something? They may not change their entire framework, but are there little things that we can help them, kind of smaller steps. And I think with the kind of families that you're describing, a lot of that comes with our modeling and our ability to show up and just be real about this journey called parenting and life, and that we're struggling too, and that's okay. Like that we have to be able to figure out how to do that together.
So it kind of comes down to family-centered care and connections.
Yes.
And we're talking so much about these community connections within whatever facility you're in. And I think you're absolutely right. It's trying to connect with them on the level they're at.
That's right.
Absolutely. So, excellent.
Yeah. Yes, we have a comment way in the back here.
I'm curious about child life specialists and how involved child life specialists are. I'm a physician and I did my training in the Midwest, and I did a rotation. Oh, thank you. Did a rotation with the child life team there and was shocked by how much trauma they were seeing and how much trauma they were sort of treating, if you will, in siblings especially, who are seeing medical trauma of their siblings. And I'm just curious, sort of maybe across the board, how involved or how much of a resource that's being utilized here.
Yeah, I can tell you, we actually got grant funding, I believe, from the Intermountain Foundation to help support the addition. And Dinah Weldon can correct me if I'm quoting the source of the funding wrong, but it was seen as such a high priority that we actually identified and was able to hire into a position for child life for our child abuse medical team. I think we now actually share that among a number of other pediatric specialties, so it's not just for our program, but shared across other outpatient specialty pediatric providers. But I think that there's a lot of things that we probably overlooked when we were building our, especially like child protection services, because we were focused on the blood draws and the evidence collection and the medical reports. And then we started to get pretty good at that, and we realized we weren't doing more holistic trauma-informed care. So this is, the child life is something that's so incredibly helpful. And, it's one of those things that I think we thought we were doing pretty well before we had it. And then we're like, when we actually had it, and they realized, oh, there was a lot, this is really much more helpful. And so then it's just a broader conversation about like, well, how do you just make sure that child life is absolutely baked into what is really standard pediatric care and family-centered care? Because these are also things that aren't billed for, right, from a funding system. So you have to then justify it as part of your infrastructure. But it requires leadership, buy-in from that standpoint. And then, once you have those folks, those of us on the ground actually doing the work, see the benefit, it's like, we're not going to give this back up.
And I will add, you mentioned brothers and sisters, putting in a plug for Primary Children's. They do SIBS Day, super important, brothers and sisters. So it's a day just about the siblings and them to come to the hospital. I actually ran the parent group a few weeks ago for this, and that community of parents and what they go through too, and able to bond there. So just a plug for SIBS Day at Primary Children's. Yeah. Do you have any other thoughts for me about child life specialists? No? Yeah. I think child life specialists should be in adult hospitals personally. For real, right? Like medical play in the hospital as an adult to be like, you're going to see this needle, you're going to do this, you're going to have this. Have your own hospital buddy to do stuff on. Yeah. I thought it'd be great. All right. Well, I want to thank our panelists, Stormy, Keri, Brooks. Thank you all for being here.